Good evening, everyone. I'd like to welcome you to the Anita's Clinical Center of Excellence, RHA Pioneer Webinar Series. This series has been developed especially for our RHA pioneers to support them in their clinical practice. Tonight we're going to talk about localization and differentiation of retinal findings with multispectral imaging with a special focus on macular degeneration at the request of our RHA pioneers. I'm Dr. Dorothy Hitchmoth, and I have lectured to all of you in the past through our Kleinman group meetings, and it's my pleasure to speak with all of you again. The format of this webinar is very informal, and I encourage all of you to ask questions as we move along. I think all of you know a little bit about my background and know that I'm both in VA hospital-based care and also own a private practice as well as some other involvements. And I look forward to sharing with you this evening. So the course objective this evening are as follows. We're going to introduce multispectral imaging technology for guest attendees who our doctors have brought on board to listen to the webinar tonight who do not have the technology in their office. So I'd ask all of you to be a little patient because some of you have heard this before. I'll provide an overview of RHA software functionality to include an introduction to RHA Atlas. I think you'll be really excited to hear about that. It's something that you'll be able to use in the clinic on the fly. I'll also provide an overview of pathology localization with multispectral imaging in general. I'll provide a quick review of age-related macular degeneration. And we'll also go through some case interpretations on select patients of interest from both my clinic and the clinics in the field that we offer this service to. And last but not least, I'll provide a chairside overview of risk factor management and nutraceutical treatments in age-related macular degeneration. And I'll include some billing tips for RHA screening and RHA diagnostic scans. So just keep in mind that MSI is really is a new way to look at all the layers or some of the layers in interaction non-invasively. We know that this works through a series of discrete monochromatic lights applied in sequence to the retina, and the image is then captured. And all of you are now aware that this really provides you with an enhanced view of the retina in a variety of different ways. A lot of you are already becoming familiar with the fact that the MSI allows for some early detection, particularly of RPE-related degenerations and dystrophies. It allows you to differentiate, document, follow, and monitor, as we've done with some of the other traditional imaging modalities, but in a much more enhanced way. Certainly provides for an interface for patient educations. And also, it's one of the best instruments that I've seen for obtaining baseline images for all your primary care patients, and certainly is a profit center and drives additional testing in the office. As you all know, it's very quick. The light flashes are low light, and the wavelengths can actually penetrate quite nicely the lens and vitreous opacities. Very easy for technicians to learn, and images can be exported in a variety of formats. I know a lot of you have already spent some time sending images to me for interpretation and advice, and I would encourage you to continue to do that. And again, remember that the retina is arranged, and there are absorbing species throughout the retina that predominate in certain layers. And I say predominate because you primarily have blood-absorbing species in the choroid. There are certain pigments in the RPE that have a primary absorbing wavelength. And then the upper layers of the retina, of course, are clear. And so, as you all know, MSI works and applies different wavelengths through the use of LEDs to those different layers of the retina. And you get a primary reflectivity from those particular types of tissues. Now, in comparison to current modalities on the market, our own eyes can see through the visible spectrum. With retinal photography and some filters, we can penetrate a little bit deeper than what we can visualize ourselves on ophthalmoscopy with our own vision, as demonstrated here. And with ocular coherence tomography, we can certainly go into the deepers of the layers of the retina in a very detailed way, but in a very small spectral slice. And as you all know, with MSI, we can image the retina across a broad spectrum of wavelengths. So I'm not going to spend too much time on all of this other than to provide a quick overview for those who are on the call who may have not seen the technology at all. Again, we can image all the layers of the retina in high resolution, the choroid, the RPE. There are a variety of ways to look at the optic nerve, and I'll go over some of those tonight, as well as image the choroid and RPE. Really is even a precursor to fluorescein, and in some cases an adjunct or replacement. And certainly this is an option for patients who we can't image through OCT, HRT, or some other testing modalities because of the near-infrared application. And so, as you know, this is a demonstration of a normal retina. This is the color image. I'm just going to walk through the different slices that you can obtain with MSI. And we're going deeper into the retina and now visualizing the RPE and slowly moving past the RPE into the choroid. This is a normal retina. This is the known as the deoxy map, and this works on the principle of highlighting oxygenated blood in the vasculature of both the retinal vasculature and the choroidal vasculature. So why is early detection important? I think I don't need to provide a lecture to make this point, but I'll say it out loud anyway. At least 1 in 3 in North America really at risk for eye disease, with age-related macular degeneration, glaucoma, and diabetic retinopathy being in the top 3. And MSI really provides a way to not only diagnose but differentiate these diseases at the earliest stages so that treatment can be applied as early as possible, or risk factor modification can be applied as early as possible. And the instrument is primarily out in optometry offices right now, and certainly we have a public health responsibility. And I think it's wonderful that we can now interface with our patients in a much more sophisticated way with this particular instrumentation. So, just to step back and away from the instrument and talking about the instrument for just a moment, our clinical goals when we have a patient sitting on our chair are really to identify patients at risk in the earliest stage of disease, if we can in fact impact that disease, identify features associated with sight-threatening lesions in the retina or in the eye, and work to slow or reverse progression of the disease through treatment and in fact risk factor modification. I think we all know that there is a lot of change relative to the research in macular degeneration. Clearly, we know that AMD phenotype is determined by a very complex interaction between genetic, the epigenetic components, diet, environmental exposures, etc. There's definitely a strong consensus in the scientific community that early detection is important, and the reason for that, and is becoming, quite frankly, center stage. And that's becoming much more important as we accumulate evidence that early maculopathy can be altered through nutraceuticals, pharmaceuticals, hormesis, diet modification, behavioral risk factor management. And there are certainly a number of studies that demonstrate how the early course can be modified by just the risk factor education. And there are at least a couple dozen drugs in FDA 1 and 2 designed to impact the pathogenesis of non-exudative AMD. Really clearly up to this point, pharmaceutical interventions have really concentrated on the sight-threatening lesions and exudative macular degeneration. And yes, the exact cause is elusive, but we're certainly coming much closer to understanding what it is that leads to RPE epitheliopathy or breakdown. But we know that that indeed is an early sign of macular degeneration. There are 5 principal mechanisms that actually lead to macular degeneration, and I'm not going to read from the slide here, and I think you have all probably seen this in the literature. But we do know that there's sort of a vicious cycle that occurs once you get once the RPE starts to break down. It sets up an inflammatory reaction that then causes more damage, and it's just a vicious cycle, and it's very difficult to interrupt. But again, we know there are ways that we can do that through nutraceuticals and pharmaceuticals now, and that's looking more and more promising. There's a simplified model of AMD pathogenesis that all of you have seen before in my lectures, And you should really understand that pathogenesis model, which I'm going to talk about momentarily here, helps us to really examine the RPE early, or MSI allows for early examination of the RPE. So as we know, RPE and lipofuscin are the predominant pigments in the retina, concentrated highly in the macula, and exposure to blue light over time actually creates a byproduct, or as a lipofuscin accumulates from exposure to blue light, there's a byproduct called A2E that creates ultimately DNA damage, which then leads to a breakdown in the RPE, which we see clinically is melanin migration, RPE dysplasia and atrophy, and drusen. And when we see those clinical signs, the disease, the train has left the station, so to speak. And the inflammatory process ensues, and you have PEDF and VEGF that are pulled into the mix to, quite frankly, repair the retina. And as we know, those also promote angiogenesis. And with angiogenesis, we have all the complications associated that in the exudative process. So just a quick overview there, just a reminder what the cycle is, where it begins, and why it's so important to concentrate early in the pathway and look at melanin disruption, and also, of course, lipofuscin. We all know how important the RPE is in the pathogenesis of most retinopathies, dystrophies, and degenerations. It's responsible for the metabolism of retinol and the visual cycle, highly metabolic tissue, provides for a local immune response, which can be good and which can be bad, produces the pigment melanin, and also works to degrade reactive oxygen species, which are created from environmental and other exposures. And of course, keeps the subretinal space dehydrated. We all know that the RPE is mainly comprised of melanin, which is easily visualized with multispectral imaging. And for those of you in the field using the instrumentation, you already know this. And it certainly is true that RPE senescence begins early in life. These are just some quick snapshots on red 3 from patients in my clinic of a variety of ages. And you can see there's RPE breakdown in patients through all the decades presented here. And these are all patients who have a significant number of risk factors for macular degeneration and no other family history of other degenerations or dystrophies that would contribute. So we can really see this in a lot of different patients, and I'll walk through this, these representations in some detail. I want to just pause briefly to remind you that the research really is supportive that in that dietary and supplemental antioxidants such as polyphenols, carotenoids, red wine, other antioxidants, vitamins A, C, and E, beta-carotene, zinc, cupric oxide, the fatty acids, coenzyme Q10, and all the others listed there have been shown to either improve visual function, slow disease progression, or are associated with the lower incidence thereof. Now, there's a little bit stronger support for the dietary consumption of these micronutrients in the early stages of macular degeneration, but there's clear evidence throughout the literature to show that nutraceuticals can impact, in fact, all stages of RPE senescence or age-related macular degeneration. There are other agents such as quercetin, resveratrol, vitamin D, B vitamins, superoxide dismutases, and others that have also been shown to influence how genes are flipped off and on, and in the end, the pathogenesis of macular degeneration. And as I said earlier, there are a number of phase 1 and 2 trials for pharmaceuticals coming. So let's just talk about risk factors briefly. And please remember, yes, go ahead. Was there a question? No. Okay.
No question.
Okay. So again, mute your phone until you're ready to have a question. That would be great. We know from research that the strongest predictive risk factors of macular degeneration are in fact age, smoking, to some degree your family history, your genes, and probably more importantly, the combined drusen and retinal appearance on clinical exam. There are other risk factors that have been nicely identified: iridescent color, hyperopia, BMI, lower levels of physical activity, impaired lipid metabolism, vitamin D levels being low, hyperhomocystinemia, and some associations with cardiovascular disease. And I just want to underscore the clinical appearance is a strong, independent, predictive risk factor in macular degeneration. And there are some comprehensive severity scales that have been used in clinical and research setting. The AREDS severity scales use drusen size and pigment change. And I'm going to talk about those in some detail for the benefit of clinical management towards the end of the webinar. There's definitely a more comprehensive model, but that was recently developed. And I'm providing the web link there, and I'll go through that risk tool as we go through the cases. And just another reminder that you really do get a high resolution view of the retina wide and deep, not to sound like a commercial, but RPE change and drusen are certainly easily detected, and knowing that those are the two important features in predicting risk for patients in clinic is important. So standard of care demonstrates that AMD phenotype is a strong predictor of disease progression, as I said earlier, independent of other risk factors and genetic testing in combination or alone. So the buck still stops in the clinic, the buck still stops with the doc, and what you see in the patient's eyes is very informative, and keep that in mind. And we talked about a lot of this already. So I'm just going to go over some definitions, because some of the things that I've been hearing from the field make me feel like the definition or the understanding of what macular degeneration has been lost a little bit, because we have these really exciting images of what the RPE looks like. So I'm going to step back and just review some basic definitions and ask that you remember these when you're looking at your patients, and I think this will help a little bit. So AMD is a disorder of the macula, and it's characterized by one or more of the following. I think there's a bit of a misnomer, particularly in the optometric community and particularly in the primary care community, that if you don't have drusen, you don't have macular degeneration. Well, that's a misnomer. So the definition says drusen formation or retinal pigment epithelium abnormalities such as hypopigmentation, hyperpigmentation, atrophy of the RPE or the choriocapillaris, and certainly neovascular or exudative maculopathy. Okay, so that is the American Academy of Ophthalmology definition. The AREDS studies have classified AMD according to drusen size and some other factors, and I've listed those as well. And I want you to just tuck these in the back of your mind, and then I'm going to refer to them later as we walk through the cases. So category 1 has no or few or small drusen, 63 microns in diameter. 2, the drusen size is typically larger, and it's also a combination of RPE abnormalities, RPE atrophy, if you will, or epitheliopathy. And category 3 consists of intermediate and at least one large drusen of 125 microns or geographic atrophy, not involving the center of the fovea. And then advanced AMD AREDS category 4, geographic atrophy of the RPE and choriocapillaris involving the center of the fovea, or neovascular maculopathy of any of the types listed here. Neovascular membrane, serous or hemorrhagic detachment, RPE, retinal heart exudates, and all of the sequelae of that process, and of course disciform scar. Remember also that the risk of wet AMD is increased threefold when any type of drusen is seen clinically in combination of hyper or hypopigmentation. So those patients are much higher risk, and I'm going to walk through some cases that demonstrate what that clinical appearance looks like. So just keep in mind, multispectral imaging does not change the definition of age-related macular degeneration. It allows for direct examination of the RPE in a way that we've not traditionally been able to visualize without some advanced diagnostics. And in my view, even with fluoresceins that I run all the time in my clinic, the view that we get to the RPE, devoid and past and around the drusen and hemorrhage is really fantastic. And certainly you all know that we can see early change and provide early risk management in the clinic. AMD is definitely the most common form of age-related maculopathy. MSI will certainly help differentiate other RPE degenerations and dystrophies. Early in the disease, it is sometimes very difficult depending on the genetic pattern or inheritance. And we all know that phenotype is variable in a lot of degenerations and dystrophies. And you may have some patients for whom you're not sure, is this truly AMD? Is this patient at risk for other RPE dystrophies and degenerations? And your clinical history will help drive that. We will have a webinar focused on differentiating dystrophies and degenerations later in the season. But keep in mind, you can also have patients with comorbid disease, and the most common comorbid RPE disruptive degenerations, if you will, are myopic and degeneration and diabetic retinopathy or blood flow to the RPE. When you go through the multispectral images, keep anatomy in mind. The upper layers of the retina are clear. The RPE is pigmented, and the choroid is highly full of blood vessels. And I'll walk you through that a little bit more detail momentarily here. So you're not exactly peeling away the individual layers of the retina with each different spectral slice, but you are differentiating and moving your visual, moving what you can see above RPE, below RPE in a very general sense, okay? Remember, the upper layers, upper several layers of the retina are clear. With the green and yellow LEDs, you're primarily visualizing superficial features characteristic of the ILM. As you move into the amber wavelength, you're going to primarily, not only, but primarily be visualizing nerve fiber layer. And as you move across all of the red images, you're going to primarily be looking just at the anterior portion, middle, and posterior portion of the RPE. And in the near infrared spectral views, you're really visualizing choroid. I put some representations with the dots on the screen there that generally show you where you're at in the retinal anatomy on cross-section as you move through those spectral slices. And that should help with interpretations that we send out into the field. So if you look at these views of OCT here, and the color representations are on the right, OCT obviously on the left, you can see that drusen, especially compared to this image here, so you can see where RPE is here. I'm sorry I don't have a laser pointer to point this out. We're on a webinar. And RPE here, the drusen are just sub-RPE, and you're going to primarily visualize those in the red 2 and 3 range. Okay, you still may see them in the amber views, but you're primarily, and they're going to be most hyper-reflective in the red spectral views. And keep that in mind. If there's a break in Brooks and there's hemorrhage, as there is in the photo on the lower photo to the right, you will actually see some obscuration of the RPE.
Joining conference.
And that will change your view. Okay? So I'm going to just remind you all to remember anatomy as you go through the spectral slices. And I know you all know that, and I'm going to go through this in some detail. This is the RHA software for those of you on the call who may not have seen it.
Joining
and conference. I will go through that in some detail. So I'm going to...
Yes.
Yeah, if you're just joining the webinar, please mute your phone. If you have a question, feel free to ask. We've had a number of people who just joined. So I'm going to briefly pause the PowerPoint presentation, and I'm going to present everyone with a new feature and RHA report that I think all of you will like very much. And that's called the RHA Atlas. Can you see my arrow here on the screen?
Yes.
Okay, great. Thank you. So shortly, RHA Atlas, which is right here, will be something that will be pushed out to your software network in your individual clinics. And you will be able to use the Atlas in the way that I'm going to demonstrate right now. So you click on the Atlas, and I'm going to pull up a sample case here. And what will pop into your view are examples of the pathology that's listed. So in this particular case, this is age-related macular degeneration here with some RPE atrophy. There'll be annotations on each slide that reveal what you're looking at any particular point that you have a pin. There'll also be an overview description below here. It's a long description of exactly what you're seeing through each one of the spectral slices. Okay, so you can read that, you can click through the spectral slices, and you'll get some information about what each one of about what you're looking at. So in this case, for example, optic nerve head is noticeably dark, potential for ischemic or hypoperfusion when there's hyporeflectivity on the oxy-deoxy map, for example. If you need to get your bearings and you're brand new to multispectral imaging, you can there'll also be reference images called non-RHA images. And in this case, we have autofluorescence, IV fluorescein, a few views of IV fluorescein, as well as OCT of this particular patient, along with the interpretations. So you'll really be able to toggle back and forth, look at the multispectral images, look at OCT, look at IV fluorescein, and whether you have one or all of those modalities, there should be something there that you can identify with and get your clinical bearings about. So as I said, there'll be a variety of pathologies. You'll be able to click right here on the Atlas and reference all of those. I'm not going to go through the few cases that we have here. So now I'm going to go right into some patients of interest, and please stop me if you have a question, because some of these are in fact from the field. So just like you would do in your clinic, I'm going to actually go to some images here. I will start with this young man here. Oh yes, one moment. Each one of these will come up differently. Bear with me here. Oh. All right, we're going to just walk through this particular eye since this is the eye of interest anyway. Nope, that's my 26-year-old. Hold on a second here. This is going to be probably the most disrupted portion of the webinar. Okay, so this is a 38-year-old Caucasian male, no other family history of retinal degenerations or dystrophies, heavy smoker, very light blue eyes. Father went blind from, quote, glaucoma, you know, where you can't see in the center of your vision. I think we've all heard that one before. Overweight, poor nutrition by self-description. And this is his screening RHA that he had in my clinic. So here we are near infrared. So there's atrophy right down through the RPE to the choroid. You're actually seeing some hyperreflective areas here, which represent literally holes in the RPE where you can actually view the underlying choroid. As you move up into anterior to the choroid, into the RPE, you can see some very nice reflective patterns of RPE atrophy, and particularly in the macula of the right eye. There's also some small areas here in the left eye. And as you move away from the RPE, the atrophy will fade only because you're moving away from the RPE. So this is more of a traditional view. And, you know, it's quite a bit harder to see that there's anything wrong in this 38-year-old. You can certainly see that he has a blonde fundus. Just looking here, you can actually see the choroidal vasculature and see that, in fact, he has very low pigment reserves throughout his retina by makeup. His oxygen map, you can see again, there's missing RPE pigment, which allows you to view straight through to the choroid. So this is somewhat akin to choroidal flush. If you have atrophy on IV fluorescein, if this does not represent a neovascular membrane here, it just represents the oxygenated blood that you can see from the choroid through the RPE because of the atrophy. I'm going to show you some other examples where there is fluid and show you how you can sort of look and use other clinical clues to help guide you in what you're looking at in your clinical diagnosis. This is also a nice example here, because I've had a lot of questions reading the POI about arterial flow and also venous flow. In some, depending on what moment the image is captured as blood, as deoxygenated blood flows through the veins, and of course oxygenated blood through the arteries. I have actually seen some images where you can see the laminar flow, where there's return of oxygenated blood on the laminar side of the venules, for example. Sometimes your veins will look dark, sometimes they'll look like there's sort of a area on the outer edge of the vein, and of course that's oxygen return on the veins. Okay, so very, very much a difference here, and again, based on the level of oxyhemoglobin concentration in the vasculature of the retina, and his stereo map, and I'm sure you're all sitting there with your glasses ready to go, but you can actually see that there's some sense of depth here, but really it's because the upper layers of the retina are clear, but there is no actual elevation. Okay. And the patient's pupils are quite small, so these are pretty good images for a screening. I was actually quite pleased to see that for this particular patient. He quit smoking. I'm happy about that. All right. So I'm primarily going to talk about AMD, but because I've had so many questions about particular pathologies, I am going to go through some others. I'm going to concentrate on AMD for right now and just walk through some images that are not necessarily perfect and that may have subtle pathology and more overt pathology. So I'm just going to walk. I'll actually start anterior and go posterior in the retina. So green here, you're primarily seeing reflectance off the internal limiting membrane. Just sub ILM, you're going to start to pick up a nice hyperreflectivity, particularly if there's a healthy nerve fiber layer. And then really amber, you're going to get just underneath the nerve fiber layer. And this is the view that if there's nerve fiber layer dropout, you're most likely to have some visualization of that. Okay, the images need to be good. You often won't see that on the RHA screening, but you have a lot of other things that you will pick up on the screening. So this is something to pay attention to when you have a nicely dilated patient and you're doing a diagnostic screening. And I'll pause there just to remind everyone, remember that the RHA screening is just that. For medical and for legal purposes and for billing and coding purposes, a screening should be distinctly different, and you should expect to pick up pathology on that screening. And this is why you have the infrared, red, and more superficial representations in that screening. But you're not going to be able to use that screening necessarily as a point of differentiation. You really need the full spectrum in a nicely dilated pupil with good technically reliable and obtained images, such as you have here. So, and again, you're going to see some technical issues in some of these, and I actually left these in here on purpose because on this particular image, you know, the technician probably should have retaken this particular slice, okay? But nonetheless, you still have a number of other RPE views. Starting in the most anterior portion of the RPE, you can definitely see migration of the RP or melanin pigment. You can see atrophy indicated by the patchy white areas where you're actually seeing down through past the RPE. And you'll see that most hyper-reflective on your red 3s and your red 4s. And as you get down into the choroid with the infrared images, you'll see that atrophy fade. Of course, this is pretty significant atrophy and should give you a sense of how significant this particular patient's AMD is. Now I'm going to show you how to toggle back and forth and look for drusen. In this particular case, there's a relative lack of drusen. There might be a couple of places here on the yellow and the excuse me, amber that show small patchy areas of drusen. And it's, remember, the combination of RPE dysplasia and drusen that puts a patient at highest risk. But even a patient with this level of atrophy, which I consider to be significant, you can employ some treatments. Okay. Are there any questions about this type of patient presentation? I'm going to move on to some other cases. Okay, so if you think back to the AREDS definition, the AREDS category 3 includes at least one soft drusen as well as RPE atrophy. And in this particular patient, you can actually see both hard and soft drusen. Even though they're sub-RPE, they're large and big enough, and they're hyper-reflective. They absorb light differently than the RPE. So you're going to see those in the image, even in the higher wavelength views, despite the fact that their position is deeper in the retina, okay? As you move into the reds, again, the drusen appearance will start to fade as you get to 3-4 and you get deeper into the RPE, into the heaviest pigmented areas, and you'll lose some sight of the drusen and you'll start to pick up areas of RPE atrophy. And again, most hyper-reflective in 3 and 4, and will start to fade in the infrared. Okay, but still, again, nicely highlights where that atrophy is, and you can actually, I like to use these views here to watch for progression. Even though you can see progression here, this highlights it in a slightly different way in most eyes, not all eyes. Okay, and then of course your color reference helps sometimes to sort of localize where the drusen are, and so this patient has hard drusen, soft drusen, and significant RPE atrophy. This is a high-risk patient, and this is the type of patient, certainly, that should be at a minimum on the AREDS formula, and clinically I put all of them on the AREDS 2 formula based on some other studies outside of AREDS that I talked about a lot in my lecture that most of you have attended. So I'm just going to show the oxy map here as well. Again, I want you to look here in this area. This represents the area where there are either drusen or there's significant RPE atrophy. Okay, this is not hyper-reflective here because there's oxygenated blood leaking. You actually can see down through to the choroid, but these are areas that you need to pay attention to. Now, toggling back and forth from the oxy map to red 3 will help you localize, is that really an area of generalized RPE atrophy, or is there something else going on there? Okay, but having said that, if you have OCT, honestly, this is a patient. If you have any metamorphopsia, you have even one single tiny little blot heme anywhere in that posterior pole near the macula, you should presume that there is a neovascular membrane until proven otherwise. And this is the type of patient you want to drive to your OCT. Okay, even a baseline is fine. But again, and you can image these areas and you can image the large drusen, but you'll get good at looking at these images and determining that in fact there's no concerning PED or other exudative lesion there. Any questions on this particular one? You guys are so quiet. Is everybody sleeping? Okay. Going to move on to another case of higher risk, a little different presentation of macular degeneration here. I think this one I need to click twice. Yes. Okay. So this is a patient who obviously has a very light fundus. You can see that by looking at the upper layers, upper LEDs. You can actually see choroidal vasculature in pretty good detail, actually, as you just head into the amber view, okay? And toggling between yellow and amber, you're going to see that the hard drusen are most hyperreflective around this level here in the arcades of both eyes. Okay, we'll move down into the reds. And there's virtually, I don't want to say none, but there's very, very little RPE pigment reserve in both maculae, or in the maculae, I should say. And as you go to 3 and 4 down into the choroid, you can really visualize the choroid, again, because there's not a lot of pigment blocking. You'll see a lot of Caucasian patients like this. And so this patient has low pigment reserves, lots of hard drusen. Yes, they're not in the macula, but in fact, this is still macular degeneration by definition. Perhaps this patient is a little bit lower risk because the location is not parafoveal. Okay. And I'm going to move over to some introduction to some other pathologies here. Eventually. All right, these folders are all set up slightly different, so bear with me here. You can see the list of pathologies here. If there's anything particular that you want to concentrate on, please let me know. I wanted this to be the bulk of the presentation, so please feel free to stop me. Okay, so I want you to primarily take a look at this eye here. And I don't think I need to explain what the pathology here is. I think everybody would easily recognize what this is. And with any retinal vascular occlusion, in this case it's branch retinal or hemiretinal vein occlusion, you're going to see hemorrhages, potentially exudate, potentially, and if it's more ischemic BRVO, you're going to see a broader representation of cotton wool spots. This particular BRVO is been in existence for a couple of months, so this is not a brand new, fresh BRVO. So you're not going to perhaps see as many cotton wool spots, or it's going to be non-ischemic. Okay, so the upper layers of the retina, you're going to see more retinal vasculature, and so you're always going to see with intraretinal hemorrhages, with the exception of sub-RPE hemorrhage or choroidal neovascular membrane that breaks through Brooks. Intraretinal hemorrhages, you're going to visualize best on the yellow and amber, again, because of anatomy and localization. You're going to see the most hyperreflective typically on yellow. They'll start to fade on amber. And as you go towards the RPE again, you're going below that vascular intraretinal hemorrhage, and the image of the hemorrhage will start to fade. Okay. Now, if you look here, you can see very subtle blur here in the image, and if you see that, you should be thinking elevation, but in this particular case, it's an artifact. Okay. And here's the color reference, and this nicely represents exactly where the occlusion is. Okay, you can see exactly where the vein is disrupted here and where there's backflow into the venial arcade, and obviously deoxygenated blood, so this is not highlighted here. If there were active leaking oxygenated blood, you may see some hyperreflectivity towards the macula because, as we all know, that's a potential space for fluid collection. So the mechanical as well as immunoinflammatory reasons that fluid will collect there. And so you cannot always perfectly rely on determining whether or not there is CME there. But this again is a patient you would drive to OCT, you would use your clinical clues, you would look for fluid on ophthalmic exam, and you would look at their acuity and monitor carefully. And the treatment here is often just to monitor anyway, so we're not going to laser a patient like this, but now there sometimes is the opportunity if there's a CME or the threat of CME for injection or in fact laser, but that really, according to all of the studies, that's not the treatment. Monitoring is the way to go there. So any other questions on that particular case?
Yes, please, John.
Sure.
On this case that you're looking at right now on that left side, how would you recommend that a doctor make that distinction whether or not that is elevated or not?
Right here?
Yes.
I would actually compare my imaging to my ophthalmic view, because you're going to look at these patients, right? You're going to look at them with the 78. Well, you should be looking at them with the 78 or a 60 wide field lens and looking at their retina to look for other clues of elevation. Now, in this particular case, let me just see if I can give you another clue here. Yeah, the pupils are actually good. There might be a little bit of astigmatism with this patient. And as you look in the green and the yellow, this looks pretty flat. The vasculature does not look like it's obscured here in any way. And it looks normal. And you always want to compare to the same area in the other eye for anatomical and symmetrical cues. Does that help?
Absolutely. Like I said, I just wanted to have some other point of reference.
Yeah, and of course, if you have OCT, this is a perfect case. You're going to drive that patient to the other modality, have them back, have another visit, do the appropriate testing.
Do you also suggest maybe just looking at the stereo view and seeing if there's elevation there?
Yeah, you can also look at the stereo view as well. You have to remember that stereo view is created from anaglyph. So if you have other views that are used in creating that anaglyph, they're not perfect, that will be off. So again, you have to go back and look at all the images and make sure that the combination that creates that is good. And I'll actually show you some other examples of that. But please stop me at will. I'm getting tired of listening to myself here. So let's go to this case here. And we are going to have another webinar on just vascular occlusions and other vascular pathologies that will be in more detail and different examples. Okay. So this I'm going to just have you ignore that for just a moment. I want you to take a look at the left eye here. And as you look in the green and yellow and amber, in the going from superficial to intraretinal space here, right in the middle, you're going to have the best view of the intraretinal vasculature, retinal vasculature. And this is a really nice case because it highlights a number of different things. So clearly there was a prior vascular occlusion. You can see some small petechial hemorrhages along the edges of the small retinal capillaries here that are persistent. You'll see that often in old vein occlusion. And you know that this was older because of the collaterals here that have all formed in this hemifield of the retina. There are some other areas down in here that are a little bit harder to see, and this you could validate with your ophthalmoscopy, but mostly look like collaterals. So this is more likely a central retinal vein occlusion because it's involving, of course, both hemispheres. There's an area here where the vessels certainly look more lacy and fine and almost look a little blurred. And so if you see that, you really want to start paying attention. Okay, so these are highly defined, they're engorged, they're intraretinal, They're not protruding necessarily into the vitreous, and so that's a clue that these are collaterals, and of course not neovascularization. And if you look on the stereo map, this area should be flat. Okay. Now, as we move over to the oxy map, okay, again, nicely defined engorged collaterals and shunts. And in this area right here, you can actually see there's some leakage of the arterial blood. Okay, this is neovascularization formation here. Okay, very different than the collaterals. I just wanted to show that example. Okay, and this is the choroidal map. And there certainly looks like there's some potential choroidal ischemia here, which of course would set you up for neovascular tissue formation. Okay, just wanted to show that quick distinction there. You'll see that often. I think, Dawn, I think you had a case like that in one of your presentations where there was some collaterals similar to this.
I did, and it was very helpful to make that distinction, like you were talking about with the collaterals versus whether or not they were leaking. She was about a year out after surgery, and did very well.
Exactly, and I'll just go back to this briefly because this patient has obviously had some treatment, has visited ophthalmology. You can see in this eye from the deep reds, okay, even though these upper layers are obscured, there's also collateralization here, some ERMA, and now this is why I forgot about this. I wanted to show you an example of how this is not a reliable view because the oxy map is a combination of the yellow and the amber, and the technician should have retaken the image here in the amber. This should have been clearer, and if they did that, then your oxy map would be reliable here. It is not reliable in this format. You can see the difference between those two image sets here, okay? So I'm not relying on this to help differentiate the vascular tissue, although having said that, I can use my own eyes here to see that there are a couple areas here of concern, that the vessels are certainly more lacy, but there's a high, there are a lot of collaterals. And if you move down into the reds, you can visualize the RPE, and you can see damage to the RPE here. It's highly focal and sort of not punctate, but highly regular, and so the patient has obviously had some prior laser treatment. So let's see here. I want to just show you some additional vascular differentiation. This is a patient from my clinic, completely asymptomatic, no visual changes, no amaurosis, Fujax, no prior cardiovascular event, but medical history of hypertension, hyperlipidemia, well controlled, strong family history of cardiovascular disease, non-smoker, in her 60s. She just went on Medicare. And so we did a screening on her. I tend to do the full spectrum screening often. And what I saw in her here, and again, greens, yellows, you're going to highlight and have most defined the retinal vasculature. And you can see nicely highlighted here in the green. And remember, a hole and horse plaque. I think most of you would be able to identify that. Sometimes people have a little bit of difficulty differentiating what type of plaque there is. If you recall, hole and horse plaque is hyperreflective. It will often look larger than the lumen of the arteriole, the retinal arteriole, because it's more refractile. In this case, because you're using the low light LEDs, you can actually very nicely see that plaque sitting right in the center of the vessel. And you certainly know it's in the vessel. As you go past, it will fade. You'll see it, though, all the way down through. It's hyper-reflective. It's a highly condensed cholesterol plaque, and so it will persist through the other images and finally start to fade here. In this case, you can also see that this is non-occlusive, okay? So this is a non-occlusive atheroma, if you will, which is what hole and horse are, right? Sometimes you can, in some cases, you can get a larger hole and horse that's in the posterior, just anterior to the lamina cribosa, and it could momentarily block blood flow or in fact block blood flow, but typically these are non-occlusive, and you can actually see that, and it's validated on the oxy map because there's certainly blood flow past the plaque. If this were a fibrin or calcific plaque, which of course localizes it to a slightly different area in the cardiovascular system typically, then you would see potentially some occlusion. So if you're having that difficulty, that will also help you differentiate from the plaque type, will change the cardiovascular workup to some degree, and assist your internist in focusing on the patient's appropriate therapy. So just wanted to show that briefly. That's not overly exciting. We see those lots, but just an example of how to differentiate and how different tissues are hyper-reflective with the different LEDs depending on location. So I'm definitely going to pull up a nevus here and just one eye. And this is something that I think is a very useful tool with multispectral imaging, is helping further differentiate, but also importantly follow nevi over time. Okay, so there's a lot of controversy in the literature, despite the fact that we have the ocular melanoma study and some other large scale level 1 studies that have nicely sort of sorted out what features constitute malignant features and what are the things that we should look for in following nevi over time. Do melanoma really derive from nevi? There's even some debate about that. Okay, so we just make that clear as we talk about nevi. But all of the principles that we've learned from all of the studies so far to date don't change as a result of multispectral imaging. So you need to remember all those principles. So symmetry or asymmetry, borders, the color of the lesion, and the depth of the lesion are all important things that you need to pay attention to. MSI helps differentiate things a little bit differently. I'm going to walk you through what I mean by that. So choroidal nevi are going to start to become visible as you get closer to the choroid, as you can imagine. And as you get sub-RPE, they're going to be nicely highlighted here. And in this particular case, all of the principles of following a lesion still apply. The lesion is evenly pigmented. It has even borders. You will notice with multispectral imaging, some of these borders don't look as perfectly smooth as they would on a traditional view or on traditional fundus photography with a variety of filters. So that's not too unusual. I'm going to show you. But again, highly regular lesion. The pigment is regular. It's not 100% smooth, but it's regular. Okay, and it will start to fade as you get down into the choroid. So it's a highly persistent, consistent lesion. Nice smooth borders. It's in a location that is sort of on the edge of the high-risk area, right? The most high-risk areas are juxtapapillary and posterior pole. If you look at the yellow and the green, so these are a little hyperreflective here, but you want to look at this level to see if there's overlying drusen, and you want to do a clinical exam and at least reference your color image and look for overlying lipofuscin, right? So overlying lipofuscin, definitely higher association with conversion to melanoma or the lesion itself being melanoma. Okay, so lipofuscin borders. Drusen is actually a sign of senescence of the lesion. It indicates that it's actually been around for a while. So drusen are not necessarily a bad thing, but they're also a way to follow changes in the lesion. On the oxy map here, if there's a break in the RPE, okay, a break in Brooks or a general break in the RPE, that could be an indication that the lesion is elevated, has changed, has grown, and it certainly broke through the upper layers of the retina through Brooks, and you will see some patchy areas here. Okay, this is still nice and even, and the color is even. And on the choroidal map, again, highly regular lesion. And in the choroidal map, you want to watch very carefully the edges here to see if there are vessels that are specifically feeding that lesion and in any pattern. And I really don't see any pattern here. So when you first look at these on MSI, they did they do look a little scary, actually. They all look like melanoma to me at first. But, just keep those principles in mind. And again, if you have other modalities and you want to get a baseline, again, this is your profit center driving to your other modalities, then you can do some OCTs through this area. You can do depth analysis with OCT. That's actually quite nice in following these lesions. And of course, the stereo map. Okay, that will give you some sense of not so subtle elevation, a little bit more significant elevation. Okay, definitely going to see a large elevated lesion with the stereo map. If you've got 1 millimeter or less, you may start to appreciate some elevation, but not in the very subtle cases. Okay. All right.
Okay, on that one, would you expect that you're going to see a little bit more of an irregular border just because you can visualize every single layer of the retina now?
Say that one more time.
Wouldn't you expect that now, because you can actually visualize through multiple layers of the retina, that those borders would appear to be a little bit more irregular?
Yeah. Yes. And
I know that it's not going to be the same at each level. Looking at a patient who has a regular traditional fundus photography, we're only seeing what's projected through, and so we're not seeing that exact detail. At least with this, we can get that detail at those different levels, at those different levels.
Right, and I actually agree with that. And you can see in much more detail at the different layers exactly where the edge is and if there are changes. Now, there's some other features that you can also use to follow the lesion over time and measure the lesion over time. I've talked to the engineering team about getting some measurement and quantification tools that I think will possibly be coming forward. It would be nice to be able to subjectively and also objectively quantify these lesions. Also, you can use some of the contrast enhancement maps. This is a software-derived way to track this lesion and just look at it and, again, measure it in a slightly different way and look at those borders. Okay. So those are some other features. I actually like this contrast map and use this quite often. Okay, so let's go on to some other. I want to try to get a little bit, at least one diabetic, a couple of vascular lesions, some AMD, and so let's.
By the way, do you have anything on high blood pressure or any hypertensive?
You mean an example?
Yes, virtuous vessels, something that we should be looking for.
Yeah, I have a lot of examples of those. And I think there were a lot of questions about changes in the vasculature that I had annotated in the patients of interest interpretation. So I don't have one right here, but let me pull up this BRVO and let's talk. I can sort of use this as a generalized example to jog my memory here about some of the vascular features that you want to look for. So this is a patient of mine from my private office. This is actually a relatively young man. He is 39 or 40, and he came to me reporting that he had hypertension in the past. And now he had lost 25 pounds and his blood pressure was well controlled. And when I saw him for his eye examination, I saw these very small little nerves, and you can't appreciate it in the right eye. And I'm going to talk about the right eye momentarily. But in the left eye here, you can see he has a very tiny disc. There is no discernible cup. And the artery and the vein are in very intimate relationship with one another. A very confined space, if you will. Against the lamina curvosa, and his eye pressure he was also ocular hypertensive, so his eye pressure was bouncing between 25 and 30 for the quick initial couple of visits that I saw him before this happened, and I placed him on IOP lowering medication, of course. And so if you look at this eye, I'm not convinced that he had controlled hypertension. I think he was so excited that his blood pressure dropped, and I actually took it in office one day, and the diastolic was in fact elevated. It wasn't too terribly elevated, but certainly wasn't in what is considered a controlled range. And so I had sent him back to his internist. I had put him on IOP lowering medications, despite a certainly healthy looking nerve. I knew this was a disc at risk. Okay. If you look at the vasculature here, you can see the venule here, the arterioles here. The ratio out in the second branches here is certainly about a 1:2. So that's, good old-fashioned AV ratio judgments. You can also see there are some crossing changes in a couple of locations. And remember, this is a younger man. So having a younger man with these type of vascular changes is significant, and you should be thinking about cardiovascular disease, and you should be referring them. If you go into the upper layers, into the greens and the yellows here, if there was significant arteriolar sclerosis, you would actually see some hyaline reflection on the arterioles, which is a secondary indication that there's atherosclerotic diseases, in addition to some of the other clinical findings you would see there. So now, of course, he came back to me for an intraocular pressure, and I had just put the instrument in my office, and I wanted to get some optic nerve baseline images with the MSI. I had already had some other optic nerve images, and much to my surprise, he was not complaining, had not noticed any vision change in his right eye, and he had stopped taking his eye pressure medication because he thought that they were irritating his eyes, and he didn't call me to tell me that. And this is what he comes in with. So this is obviously a central retinal vein occlusion. It's partially because of uncontrolled hypertension, poor pressure perfusion, increase, that is caused from the increased intraocular pressure, and this unfortunate anatomy that this patient has. So you can clearly see all the classic features of a vein occlusion here: engorged venules, tenuous arterioles. You can nicely visualize those and the distribution. My thinking was this is fairly fresh, but there were not a lot of cotton wool spots, which you would see around this level of the retina. And these are not perfect images here, but you can also see a little bit of RPE atrophy in this area, and certainly some blurring of the edges of the optic disc, which you can also see elevation on the stereo map. So there's confirmation. Of course, you would expect this. You can actually see it on fundoscopy. This is kind of a no-brainer. And then I want to show you this example of the oxy map. Okay, I'm going to pull this up, and don't forget to use the magnification tool on the software. Okay, so central retinal vein occlusion. Going to watch these patients very closely for sequelae. These patients are high risk for development of neovascular glaucoma, certainly in the first few months. It's particularly if this was ischemic. In this case, it was more mechanical. But you can see a very, very subtle area here near these capillaries where there's some hyperreflectivity. Okay, so this patient has some macular edema. Okay, as a result of the central retinal vein occlusion. And that's not peek through from the choroid, right? Your reds are relatively intact there, okay? It's a little bit of subtle, and you would potentially expect this with this clinical presentation anyway. Okay. Any questions on that? Just going to move on to one case of diabetic retinopathy here. This was one from the field, so somebody might recognize this. This is a relatively classic example of a patient with diabetes, non-proliferative diabetic retinopathy. I'm just going to walk you through the different lesions that you can see here in the arcades and what you would expect to see and where they would be hyperreflective, and how you differentiate just a little bit in a patient with diabetes. So again, Exudates and hemorrhages are intraretinal. They're above the RPE. They're always above the RPE unless you have a massive exudation as a result of sub-RPE lesion associated with RPE disease, as in macular degeneration. So you're going to be able to visualize exudate. Exudate will be most hyperreflective in your yellow. You can see exudate here, okay, and also see fine blot hemes in about 3 quadrants here, and we divide this up, just about all 4 quadrants here, also a flame hemorrhage as you would expect. And you know where those are because as you go down closer to the RPE, those hemorrhages will fade. The exudates are more optically dense, and so those will persist through the images. And you can also see in the 3s and the 4s that there's some RPE atrophy in a few places here, which is what you would expect in a patient with diabetes, right? Diabetes is a vascular disease that affects the choroid, which affects the RPE, so it's not unusual, and you will see more RPE atrophy that you might not have appreciated before in patients with diabetes, and certainly with diabetic eye disease, diabetic retinopathy. They could, of course, have comorbid presentation. They could also have macular degeneration as well as this type of clinical presentation. And again, you can look at the stereo map to look for elevation, but really you still need to rely on your 78 and 60 diopter lens and then go back to your reference images here in MSI to look for subtle elevation. By clinical definition, this is not CSME. There are not exudates within 500 microns of the macula. There's no appreciable thickening within 500 microns of the macula, and there's no elevation at the macula. Okay. I thought there might be some. Nope, nerve is okay. And I'm going to pull up at least one optic nerve case here. Okay. So I have the answer and the diagnosis right there, but I think an obvious finding of, now this patient, I should back up and tell you a little bit about this patient. This is a 24-year-old female, again from my private office. She is a very low myope, -1, and she came in and she was frightfully thin. She had lesions around her lips and her mouth. They were just looked like a dermatitis, but not inflammatory. She had lesions on her skin, and she came with her mother. She was visiting, and I took a look at her retina, and I certainly saw significant some peripapillary atrophy, as can be seen here in the reds, and certainly significantly here. There's certainly some asymmetry to the disc, but these are slightly different angled images here. If you look at the stereo map, there's certainly some central atrophy and deepening of the cup here. But of most interest here, so you're thinking, okay, does this patient have glaucoma? She's young. She had no other secondary findings, normal IOP, certainly not a vascular path, no family history. And after much discussion with her and her mother, she had severe and suffered for many, many years from anorexia nervosa. And I did a visual field, but this is what her nerves look like on the oxy-deoxy map. So clearly she has some optic atrophy here. And this is a typical appearance you would get from someone who has chronic nutritional deficits. She actually had such a severe vitamin. I've referred to her to a variety of people after that. She's actually doing much better. But, you know, this is irreparable damage to her optic nerves. She actually had scurvy. Her vitamin C, her nutrient level was so low, vitamin C was so low that was the cause of the lesions and the breakdown on her lips and, in fact, her tongue and some other mucosal tissue areas. But I just wanted to show you, this is an example of a hypoperfused nerve from toxic optic neuropathy in a patient who also happens to have some fairly large cups, but a lot of this is also from the disease itself. So just kind of an interesting case. So we're coming up on about 7:30 here. I'm going to end the cases here unless there are any other questions. I'm going to go back to the presentation eventually. Get rid of this. And I want to talk about clinical management relative to macular degeneration because I've had a lot of questions and calls and emails because people are seeing more RPE atrophy, they're seeing more RPE breakdown, they're seeing drusen, they're seeing more drusen, and they're seeing combinations of those clinical presentations both in the macula and outside the macula. And the first thing I would say is to remember that macular degeneration is really a pan-retinal disease. There's breakdown in the RPE, and the severity or the presentation of that changes. And of course, people who are highest risk are those people who have maculopathy, and those are the ones we pay most attention to in terms of wanting to preserve their sight. But everybody is important to screen and talk about risk and apply all of the tools that we have at hand now. So this is an overview of the chairside guide that will go out to the docs who are RHA pioneers on the call. We're tuning that up just a bit over the next week or so. But remember that early AMD includes no clinical sign of the disease or significant risk factors, okay, according to AREDS categories 0 to 1. So I think it's a no-brainer that for patients who have high risk, family history, light irides, etc., we should be educating those patients at a minimum to quit smoking, avoid secondhand smoke, make sure they have a healthy diet that's certainly rich in the carotenoids that are important for fortifying the macular pigment, having a diet rich in antioxidants, eye foods, so to speak, and that includes all of the things that everybody knows about, the dark green leafy vegetables, all the colorful fruits and vegetables, and as well, according not just to the studies relative to eye disease, but also the American Cardiac Association, the relative equivalent of 3 servings of fatty fish per week. You would consider using lutein and zeaxanthin if the patient has an admittedly poor diet. I use the higher dose of each one of those. They should be consuming EPA DHA in the amount that I have listed there. Lower their BMI if their BMI is in the above average range or quite frankly too far below. UV protection from blue light. Exercise according to the American Cardiovascular Association recommendations. And you may do genetic testing if there's a very high risk or strong family history, but really clinical appearance is going to drive the risk almost equivalently, which is why the American Academy of Ophthalmology has actually said there really is no reason to do mass genetic screenings on the population to sort of find out who's at risk for sight-threatening lesions. Really, you're just going to narrow it down and focus on the highest risk patients according to clinical appearance and risk factors. And I'll talk about that a little bit more in just a moment. So for patients who have intermediate or AREDS category 2 and at least one eye, you're going to do all the things on the prior screen as well as the AREDS 1 formula. I add alpha lipoic acid, also the carotenoids, all the other things listed there in the AREDS 2. In addition, the DHA, EPA, and the dose listed there, okay? In May, hopefully we'll have AREDS 2 data coming out, May 2013 here shortly, that will help drive and define that a little further. But this is what I'm doing for those patients now based on other studies that support using that combination of nutrients. For advanced AMD, all of the above for 1 and 2, and also additional counseling on risk, vision monitoring. Consider resveratrol in patients who have no remaining anti-VEGF or medical treatments available to them through ophthalmology. These have to be really cases where there are no options. Having said that, I think we'll get some good literature coming out on resveratrol in very specific doses that will help support possibly using that earlier in the clinical disease, but there's no good evidence to support that right now. Having said that, I'll tell you I have some family members on that who are a little bit lower risk. And you want to be a little bit cautious about the use of resveratrol. You can't use it in combination with statins, and there are some other contraindications. And I'll show you how you can look for and sort those contraindications out. Additional considerations: if your patient is a female, you also want to check total vitamin D and correct. You also want to add folic acid and some of the other B vitamins in the doses that I mentioned here. I do a little bit extra. I also check for hyperhomocystinemia in people who are at risk for or have strong family history of cardiovascular disease. That is relatively easily corrected with B vitamins in the appropriate dose, if the patient is compliant, of course. And check for other risk factors for cardiovascular disease. Involve their primary care doctor. Really take a look at whether or not they should be on aspirin therapy and also calcium therapy. The American Cardiac Association is now cautioning people that if you've not had a myocardial infarction, if you have, moderate risk for cardiovascular disease, that taking aspirin before an event may actually not be beneficial and, in fact, could be harmful. So watch the studies on that. We know that in women, the ophthalmology research is showing that aspirin can actually is potentially associated with the progression of macular degeneration, specifically exudative macular degeneration. And of course, JAMA had the big splash last week with relative to calcium, so you want to be very, very careful. Talk to your patient about what their calcium supplementation is. Coordinate with their PCP, make sure they're taking magnesium and vitamin D3 along with their calcium, and probably 1,000 milligrams is probably too much for most people according to the latest study. So I would say pay attention to that and be cautious about it and talking to your patients. Now, if you want to do a little bit more detailed risk profiling of your patients, chair side, I like this risk calculator. This is the one that's being used right now in the field. It's the most popular one, and it has the most considerations based on the patient's risk factors, their retinal exam, genotype is something that you can use in the risk calculator, but it's not necessary. You get almost the same risk calculation in the end with or without the genetic testing if you have the other information accurate. Okay, so that's another tool. And this is advanced AMD risk calculation. So based on your clinical appearance, patient's age, their family history, their smoking status, you can predict what their relative risk is of developing exudative macular degeneration over time. Just going to give a little nod here to the two of the omega-3 fatty acid supplements that I like and have the highest dose and the most appropriate dose of DHA EPA in the least expensive cost, dollar for dollar and dose for dose, and is in liquid form, is Carlson's and also Barlean's. Any of those products, I do prefer the liquid. 1 teaspoon a day will get you the appropriate dose and is a much, much lower cost for most patients. Some other tools that you can use chair side, it's getting very complicated with patients being on long lists of medications, and then you're going to give them supplements, and there are all kinds of medication, food, and nutrient or supplement interactions. You really need to make sure if you're going to put patients on these different nutrients that you check against their medications. We need to start looking at nutraceuticals just like we do with pharmaceuticals. You need to ask about that diet. I mean, everybody knows about coumadin and about coumadin and green leafy vegetables, and watching and checking. So what do I see at the hospital? They're on coumadin. Their doctor tells them don't eat anything green, and then they also have macular degeneration. So you really need to balance that. You need to talk to primary care. You need to check those nutrients. And there's some websites here that you can do that very easily. If you want to check for the purity cost
purity and cost and the ingredients of supplements, by far and away, Consumer Lab is, I think, probably the best. You have to pay a subscription. That subscription actually supports the independent testing that they do on all supplements, and it's very rare that I will enter a supplement. I do this right while the patient's here if they bring their bottles in, which I make them bring all their supplement bottles in. If they don't do it on their first visit, I hound them and have them do it on their second visit. Conference. And I look at all the different nutrients. So, again, healthy diet. The mypyramid.gov is still nice education. They've changed their education platform, but it's another resource for patients. Some very nice color printouts. There's also list of high risk supplements from the NIH and some other government resources. And what else do I have here? The Ocular Nutrition Society, which all of you know, I'm a fellow with the Nutrition Society. They have some very good brochures on ocular nutrition. They also have, if you want to do what I call ultra prevention and incorporate diet and nutrition in a little bit more defined way into your clinical practice, the ONS has a patient nutrition survey that's comprehensive. It's really designed for the patient to take it home, and that comprehensive survey actually helps delineate where patients' diet may be deficient and what nutrients they're deficient in. You can also send them to a nutritionist. Seems like an old-fashioned concept, but I highly encourage, and I actually use somebody who's a fellow in the Academy of Alternative Medicine to help these patients get their diet on track if they're willing to drink the Kool-Aid, so to speak. I mean, you have to have willing patients. Otherwise, all the advice that I'm giving you is null and void. The AOA also has some brochures, and there's some other websites of my favorite vitamin supplements relative to AMD. Clinical management just puts some of the more prevalent codes that should be used for RPE atrophy, drusen, or both, if you're indeed making the diagnosis, and some other code combinations that are important from a clinical management profit side. And don't forget about your quality codes, and I listed those there as well. So again, like I said, the chairside guide will be available to RHA Pioneers. It will be more detailed, but I certainly provided an overview of that information. And I hope the definition and the stages, the clinical stages, using ARED staging here will help guide you in what nutrients you should be prescribing to your patients with some confidence. And of course, we all know the benefits of multispectral imaging. We've gone over some of that tonight, and detection differentiation certainly can act as a profit center. And we know what's coming on the horizon for its modular capabilities. And last but not least, don't forget that the Clinical Center of Excellence, we're still going to provide the POI service to new pioneers, and that will continue for your typical pioneer period. RHA Atlas is coming, and I showed you that earlier in the presentation. We still offer curbside virtual consult, and you can do that by emailing me. And I see that it says Hitchmoff at Anitas there. It's D. Hitchmoff at Anitas. We provide clinical expertise through not just through me, but also through a team. Occasionally, I will send out an image to my own team and ask for advice, technical support. And we have a new group where you can teach one another. We developed an iDoc to iDoc at Google Groups. We'll be inviting you to that very shortly, so be on the lookout for that. And that group is designed so that people can pose questions in real time. Other docs can answer questions in real time, and I'll be monitoring that. So I want to thank everybody for their attention this evening. Thank you for attending. This is the first in a series, so please, the Clinical Center has been designed to offer you the clinical education that you need, that you want. So we will modify our presentations and present the topics that are of greatest interest to our doctors in the field. So please email your ideas to me, or talk to Barry McDonald or Stephen Mulvihill, who are out in the field, and we'll certainly take your feedback into consideration. So thank you, and I'll take any questions now if anybody has any.